I'm Dr. Aditya. I'm actually a consultant in internal medicine and I specialize in clinical immunology and rheumatology. And welcome to my channel. I'll be discussing cases symptom wise, going symptom by symptom, and then progressing to their relevant illness scripts and the approach to each individual illness script. And then we'll be discussing a very important component of internal medicine, which is usually ignored. That is a detailed understanding of the radiological substrates that result in our that are present in our patients, because often the diagnosis is made with radiology. So for our first case, there'll be a case presentation, and then after that, I'll progress to the analysis of the case. First case, we'll be discussing the case of a 33-year-old lady with no known prior comorbidities who has been developing a gradual onset of progressive shortness of breath for the last 6 months. She noticed it while having to climb 2 to 3 flights of stairs, but later she had shortness of breath even with activities of daily living. There was no chest tightness, no difficulty in exhaling, no coughing up of blood, no chest pain or discomfort within the chest, and there was no alteration in the shortness of breath with change in position or pediatric. Okay, so we'll be analyzing the symptoms that we've just come across. So basically, our patient is a 33-year-old lady with no known prior comorbidities who's presented with a gradual onset progressive exertional shortness of breath, which she noticed while climbing stairs initially and then with activities of daily living. There are no actually any other pulmonary symptoms or cardiac symptoms, so that leaves us a little without really any clues to go after from history. But sometimes not having clues is itself something that we can work with. So let's see how this pans out, and first let us decide how to localize cardiopulmonary symptomatology, particularly shortness of breath. So first step to any type of medical diagnosis usually is to localize it to a particular tissue. Now, there are different tissues within the human body have specific symptoms or rather specific physiological functions, and abnormalities of that physiological function are actually what result in the symptoms that the patients come with. However, multiple symptoms can occur because of different perturbations in physiology, and similarly the same tissue can be affected in different ways. So the same tissue may be functioning in 2 or 3 different ways, and those 3 different physiological functions may be affected to different degrees in a given patient. So although localizing of pathology is the first step, in most cases when we do this, we are actually using an anatomical framework to approach the disease. So through our journey through internal medicine, we'll be discussing situations in which a physiological or a biochemical framework is more appropriate. However, for our first case, I wanted to keep things relatively simple. So we'll be discussing chronic shortness of breath through the lens of an anatomical framework. So in that vein, I've shown you a schematic diagram of the respiratory tract. Now, the respiratory tract here is shown to be to consist of the trachea, the primary bronchi, okay, and the primary bronchi then undergo 23 divisions subsequently. The last 7 of those divisions are what constitute the distal airway. The distal airway then progresses or opens up into the alveoli, and the alveoli are actually right next to the alveolar capillary bed, so that gas exchange can occur to and from the alveolar capillary bed. Now, both the alveoli and the alveolar capillary bed is actually housed or enmeshed within a very fine interstitium, at least in physiological states in a healthy person, a very fine interstitium. And this entire apparatus is then in turn housed within the visceral pleura. Okay, so that is actually what we call the lung. Now, outside of the visceral pleura, there is a potential space that outside of which there is what we call the parietal pleura. The parietal pleura, importantly, is the only pain-sensitive structure within the lungs, and importantly, as we'll see subsequently, I'll be using two other pulmonary symptoms, that is cough and hemopsis, to localize the cause of shortness of breath. However, I will not importantly be using chest pain except in the case of pleural effusion. And importantly, all three of them will deserve their own diagnostic frameworks and will be discussed in subsequent videos. However, for the evaluation of chronic shortness of breath, I will be restricting myself to do those two uh, other symptoms, that is hemopsis and cough. Now, outside of the visceral pleura, we've got the parietal pleura. And outside of the parietal pleura, below we've got the diaphragm, and on the lateral side we've got our chest wall, which then consists of the ribs, the soft tissue in between, the muscles. Okay, so when we talk about the proximal airway, the proximal airway contains smooth muscle. Okay, so it contains smooth muscle. In addition to that, there is a cartilage skeleton. Okay, there's a cartilage skeleton there, and there are some mucous glands, although they are not florid. There are not a lot of them. Okay, so you've got smooth muscle, you've got a lot of cartilage, and we've got some mucus producing glands. Okay, the distal airway, on the other hand, has a similar amount of smooth muscle. Okay, no cartilage, and has got a lot of mucus producing glands, and additionally a specialized cell called the Clara cell, which actually produces mucus. So it can produce a lot of mucus. Okay, so as we'll see subsequently, this is relevant to the symptomatology localization. Okay, now the after the distal airway, the alveoli, the interstitium, and the pulmonary capillary bed, they are all three responsible for gas exchange. Now, because they are responsible for gas exchange, naturally the primary symptom of the patient will be shortness of breath. So there's no doubt in that. That is pretty obvious. Okay, primary symptom is shortness of breath. Now, that becomes very clear. Okay, there are some other considerations that we need to go through when we talk about the pleural pathologies. So we'll come to that. Okay, now in the proximal airway versus the distal airway, what I would find is in proximal airway disorders, particularly the two disorders are asthma and COPD. So cough could occur, but would likely be non-productive. Okay. Now, shortness of breath would occur naturally, but why does the patient have shortness of breath? It is because the airway has contracted. Okay, so that could happen persistently or it could happen episodically. Either way, the patient then will say that there is a difficulty in breathing out or difficulty in exhaling. The other issue is because there is a difficulty in exhaling and no difficulty in inhaling, a little bit of air gets pent up within the alveolar space with each respiration, and that ends up causing the chest to expand. Okay, we'll discuss this more when we discuss pulmonary function testing in the third video in our series. However, for now this much is sufficient. Now, hemopsis in both, as in asthma, it is not likely to happen. In COPD, unless there is distal airway involvement, it is unlikely to happen. Now, when you have distal airway involvement, a variant of COPD called chronic bronchitis and bronchiectasis are the two prominent disorders that we talk about. Now, as you can see, in both of these disorders, a cough is a prominent symptom. Now, the cough here is a very prominent symptom, and with bronchiectasis, because of the type of pathology that we have, the cough is actually very florid. A lot of cough is often there. Okay, an exception to this rule is what is called bronchiectasis sicca. So bronchiectasis is defined radiologically. So there is a subvariant of bronchiectasis in which you don't get a lot of cough production. So it is dry, and the Latin term for dry is sicca. So that is where the etymology of the word comes from. Now, importantly, both cause dyspnea, and the dyspnea would be very similar to the dyspnea that you get with proximal airway disorder. That is a difficulty in exhaling and inability to and a certain chest tightness. Okay, but it may not be as prominent. Okay, it may be, but it usually is not. Okay, now the distal airways are actually the most common site of hemoptysis, epidemiologically speaking. So this is a epidemiological thing that I'm talking about. Okay, so it is not based on the cytopathology or anything like that. It is just purely based on epidemiology. Okay, so this is particularly the case in disorders that I actually specialize in, that is rheumatoid arthritis, SLE, and IPD, and we'll get to the details of that a little bit more subsequently. Now, the alveolar disorders actually have prominent shortness of breath, which is obviously to be expected because it is the alveoli that are the site of gas exchange. So even if the air reaches the alveoli, it's likely that gas exchange will be hampered if there is some pathology within the alveoli. Okay, so if I make a similar table of cough, dyspnea, and hemoptysis in patients with alveolar disorders, see, as you can see in all of these disorders, so the main complaint will always be dyspnea. Okay, however, now depending on the type of pathology, hemoptysis may or may not be there. Okay, so as you can see with pneumonias, now I'm using the term pneumonia here very loosely. Basically it means an inflammatory infiltrate within the lumen of the alveoli, so which may be infective but also may not be infective. So depending on the type of pathology, there may be a breach in the capillary membrane and then the lining epithelium of the alveolus and bleeding into the airspace. Now similarly, malignant processes obviously don't respect tissue boundaries and go through facial planes, so they can definitely cause hemoptysis. The other entity that I need to bring your attention to is actually pulmonary edema. So we'll be having a dedicated discussion on pulmonary edema because there's a lot of misconceptions regarding what constitutes pulmonary edema. Is it just left ventricular function a dysfunction? It is not. Okay, so spoiler alert, there's more to it than that. And with diffuse alveolar hemorrhage, as the name would suggest, there is bleeding into the alveoli. So bleeding is usually a symptom, but up to 50% of patients with diffuse alveolar hemorrhage have no hemoptysis. So that is something again that we'll discuss in a second. Now similarly, see, the interstitial disorders and pulmonary vascular disorders also have prominent shortness of breath because the blood within the pulmonary vasculature is what is receiving the oxygen and giving away the carbon dioxide. And similarly, when there is an interstitial pathology, usually the thin basement membrane between the capillary and the alveolar epithelium becomes thickened. And as we know from Fick's law of diffusion, if there is an increase in the distance that the metabolite or the compound has to diffuse, the diffusion decreases. It's inversely proportional. So let's fill in the blanks here. And with pulmonary interstitial disorders, they come under a large headache, the interstitial lung disease. Now, interstitial lung diseases will be again a discussion in a subsequent video, likely 2 videos. And the important thing is, just like alveolar disorders, it is the dyspnea that is the prominent symptom. Now, see, interstitial lung disease, a subvariant of interstitial lung diseases, that is fibrotic ILD, tends to cause a lot of architectural distortion, okay, within the lung, and that tends to activate pulmonary unmyelinated fibers, what are called J receptors, and that results in a dry cough. This may occur. If not there, it doesn't really rule out ILD, but when it is present, it helps you differentiate it from pulmonary artery hypertension, because pulmonary hypertension often presents only with shortness of breath, gradual onset progressive shortness of breath, and essentially nothing else. Okay, now with pulmonary vascular disorders, there are 3 types. There's pulmonary hypertension, there is the development of pulmonary emboli, and there are structural abnormalities, that is AV malformations within the lung. Now, pulmonary hypertension presents with shortness of breath, as we discussed. Hemoptysis may occur, may not occur. Pulmonary embolisms again present with acute shortness of breath. So that is not a consideration in our case. I've just added it for completion's sake. And structural abnormalities, importantly, usually are asymptomatic, may sometimes cause bleeding. They usually don't cause much shortness of breath. Okay, so they're not significant differential. Now, changing track. Now, what is the cause of shortness of breath in a patient with a pleural? The diaphragm, actually, the central dome of the diaphragm that has been shown here, that is at the highest level, and then the fibers of the diaphragm go and insert on the chest wall. Now, when the fibers contract, the diaphragmatic dome is pulled down. Okay, that increases the craniocaudal dimension of the chest wall, and that in turn is what is responsible for producing your tidal volume. Okay, the amount of breath that you take in during a respiration, normal respiration. Now, as you can see in the diagram on the right, if there is a pleural effusion, that distorts the shape of the dome of the diaphragm underneath it. Now, that results in a change in the direction of the vector of pull in the muscles of the diaphragmatic that side of the diaphragmatic lobe. So, because of that, instead of being pulled down, now the diaphragmatic tendon is actually being pulled towards the right side. So because of that, the amount of force that is pulling down the tendon actually decreases. And when that happens, the tidal volume decreases. So once the tidal volume decreases, the patient has to breathe more number of times to maintain their minute ventilation. That is the tidal volume times respiratory rate. So once the tidal volume comes down, the respiratory rate must increase. And that obviously requires a lot more work of breathing. And that is appreciated by the patient as a shortness of breath. Now, importantly, if this patient with a right-sided pleural effusion was to lie down to the right side, what would happen is that this fluid that was there in the pleural space here would actually move into the sulcus, that is the most dependent portion. And as a result, the diaphragm would return back to its normal shape. Now, when the patient inspires, the diaphragmatic fibers contract and pull down the tendon. Okay, so in that process, what happens is that the tidal volume returns back to normal. So, funnily enough, in a patient who of a right-sided pleural effusion, if the patient lies down on the right side, the shortness of breath actually decreases. Now, see, if there was no pleural effusion, just pleuritis, the patient would have pain on that side because of inflammation of the parietal pleura there. Now, lying down onto the side of the pain would actually result in the patient's or chest wall being prevented from actually expanding. So because the pain of pleuritis happens because of visceral and parietal pleura rubbing against each other, this decreased movement on that side would actually decrease the pain. Not the shortness of breath, but decrease the pain. But that leads us to a rather interesting general statement. That is, when you have a pleural pathology on one side, implying either an pleuritis, lying down on that side actually improves the patient's symptoms, be it shortness of breath or chest pain respectively. Now with parenchymal pathology, things are a little different. Okay, so there's a right-sided parenchymal pathology in this case. When the patient lies down to the right side, what happens is the right lung gets more blood flow than the left lung, and in the lung that is pathological, gas exchange is not happening or is happening at a decreased rate. So you're increasing blood flow to that area of the lung that has got poor ventilation. That is not it is not being able to exchange gas effectively. Okay, exchange oxygen, carbon dioxide effectively. So that results in a ventilation perfusion mismatch. Okay, and a worsening of the symptoms. Okay, so even from history, if the patient's pathology is unilateral or at least significantly unilateral, can decide whether the pathology is on the right side or the left side, provided you are able to prove later with physical examination that it is either a parenchymal pathology or a pleural pathology respectively. Okay, fine. Now, in summary, at the end of our first discussion, this is what I would like you to understand. Okay, so these are the tables that I would like you to understand, and I would like you to apply it in our case and in all cases of chronic shortness of breath that come to you. Okay, chronic shortness of breath naturally means a shortness of breath that has lasted for more than 4 weeks. I should have mentioned this in the beginning, but it is more than 4 weeks. So in summary, A patient with chronic progressive exertional dyspnea without postural variation, chest tightness, cough, or hemoptysis could have either alveolar disorders or could have a pulmonary interstitial disorder or pulmonary vascular disorder. Now, there is a small possibility of there being a pleural disorder. We'll get into it in the at the end of the series. However, the lack of postural variation in the shortness of breath, the lack of chest pain makes a unilateral pleural effusion extremely unlikely. Okay, so these are our three differentials, and these will be the diagnostic frameworks that we'll be delving into in detail. But before that, we'll be discussing pulmonary auscultation, pulmonary physical examination, in particular pulmonary auscultation. We'll also then discuss cardiac physical examination, excluding examination of cardiac murmurs because that warrants its own separate series. And we'll be then discussing the evaluation of pulmonary function tests as well as 2D echocardiograms, primarily their interpretation, in order to be able to better understand how, in a clinical scenario, these three types of pathologies are likely to present to you. So I'll see you in the next video. Thank you.